Okay, so we're going to get started. So tonight we're going to do 2 chapters. We're going to do the abdominal emergencies and the behavioral emergencies. Not much really super to talk about behavioral emergencies, so mostly we'll be concentrating on the various different abdominal emergencies. In all honesty, also with abdominal emergencies, there's not much in the pre-hospital setting that we could really do for people having abdominal emergencies, but it's really recognition. So we'll go through some of them and just talk about the different signs and symptoms. Pretty much the treatment is always just going to be oxygen transport because, you know, this is not anything, even on a paramedic level, that there's anything really to do for these patients. Just need to get them into the hospital. Okay, so.
Should we be seeing something on the screen or no?
You should be seeing something. I just realized. Let's see. Let's see.
There we go.
Better now? Okay. Now, let me just move this over. Okay. Okay, so let's just review the anatomy and physiology of the digestive tract, and then we'll get into some of the different emergencies. Okay, so we know that the abdominal cavity has many, important organs, obviously, many organs from a trauma standpoint that can bleed a lot, right? So from a trauma standpoint, injuries to the abdomen, probably, third down, I would say, head, chest, and then abdomen as far as order of severity, but, they're all important areas, no place good to have any trauma and stuff like that. So we'll talk about the different parts over here. So now this is the important down here. It's not important for us to be 100% certain of what we think is wrong with the patient when they're having an abdominal complaint. Like I said, it's more or less just bringing them to the hospital, because even in the hospital, it's either the diagnosis is either going to be based on blood work, CAT scan, or an ultrasound, or a combination of probably all three, actually. So there's no way that we're going to be 100% certain what's going on with the patient. The more experience you have, the more or less you can kind of get a good idea of what you think it is, but there's no way that you would be 100% certain what's going on. So your abdominal area, okay, or your abdominal cavity is basically between your diaphragm. So superiorly, it would be your diaphragm. Okay, and then inferiorly would be your pelvis, okay, the bones of your pelvis. And then obviously in the front, okay, anteriorly would be your muscles of the front of your abdomen. And then posteriorly to the back, there's a sheath of muscle called your retroperitoneal muscle. And that is what makes the back. Now there's some organs of the abdomen that actually exist behind that, like your kidneys, but I'll show you that as we go on. So we know the purpose of the organs in your abdomen are digestion, right, is the main purpose, right? So the food comes, or actually digestion starts by the chewing of the food and the mixing of it with saliva. Then we swallow it into our esophagus or our food pipe, okay? And that's the more posterior of the two pipes. The anterior pipe is your trachea. Your posterior pipe is your esophagus. When it gets down into your stomach, the upper part of your stomach has acid that starts to work on the food, and the lower part has bacteria that starts to work on the food. So by the time it gets out of the stomach, it does not look like what you put in your mouth. Okay, it's basically kind of all mushed up type of substance at this point. And as it travels through the intestine, okay, it starts with your small intestine. Again, remember, your small intestine is not small lengthwise, it's small diameter wise, right? So, but it's very long, 20-something feet long, but the diameter is not that great. And then it goes into your large intestine. Your large intestine diameter wise is much bigger, but it's only a couple feet long. So, and then by the time it travels through your intestine, everything good has been pulled out, including fluid, okay? And then it goes into your rectum, and then you defecate it or, poop it out. Okay, so that's basically how it works. Also in your abdominal cavity, okay, is your reproductive organs, okay, or especially obviously a woman's reproductive organs. And then certain organs that are involved in digestion also play a role in different endocrine parts. So like tomorrow night when we talk about diabetes, okay, we're going to see that the pancreas, okay, has a role for digestion, and the pancreas also has a role in producing insulin and glycogen and glucagon, different hormones that play a role in sugar control. Okay. Again, on the exam, the questions I typically would see them ask as far as location and stuff like that, they usually ask, what's the large organ in the upper right quadrant? Okay, and that's going to be your liver. Remember, your liver does travel over, okay? This is not like a separation, but there is a little groove between the main body part of your liver and the tail part of your liver, okay? And actually fitting in that groove is a ligament, like a strong rope-like band of tissue that actually keeps your liver from moving around inside your abdomen. So this one's called the ligamentum teres, or round ligament. And then there's another ligament that holds your liver up this way, because your liver, weighs a few pounds. So if it wasn't anchored in place well, you would know about it every time you're moving and stuff like that. Your pancreas, again, is typically considered to be an upper right quadrant organ. Some books have it upper left. Weight-wise, it's probably equal, because the fatter part of the pancreas is on the right side, the thinner part is on the left side. Okay, your pancreas, again, plays a role in digestion, and your pancreas also plays a role in producing the hormones that control sugar. Upper left is going to be your spleen. Okay, spleen basically plays a role in breaking down or getting rid of the older blood cells, and it also is a reservoir for some well, I guess we could use the term a reservoir, but it's like there's always about 500 mLs of blood in your spleen. So that's why, from a trauma standpoint, it's an organ that, when bumped or hit, tends to bleed a lot, but it also has the ability to pump that blood back into the circulatory system if we need it. Okay, here it's showing your two kidneys. So you got kidney and kidney. It's partially hidden by the liver, looking like they're kind of next to the other organs, but they're actually behind the spine, okay, where these other ones are in front of the spine. Okay, and then you see you have your stomach. Okay, your stomach goes into your small intestine. Okay, and then your small intestine connects to your large intestine, and your large intestine connects to your rectum, and then you go to the bathroom. Okay, so everything is tightly fitted in there, and you have your bladder for your urinary tract. That's what holds your urine. You see also here upper right quadrant gallbladder. Okay, another organ that does play a role in digestion, but if needs to be taken out, can be taken out. Again, your stomach is a upper left quadrant organ. Liver would be upper right quadrant. So that's basically what they're looking at. Remember, the dividing line to divide the 4 quadrants is your belly button or your umbilicus, and you just draw an imaginary horizontal line, imaginary vertical line through your belly button or umbilicus, and then it divides into 4 quadrants. And then the typical lower right quadrant organ would be your appendix. Okay, you don't really see it here. Your appendix is kind of where your large intestine and small intestine meet. There's a little finger-like projection that hangs off of it, and that's your appendix. Doesn't really have any super role, although it's usually populated with a lot of bacteria, which they think has some purpose, but that's why when a liver is ruptured, I'm sorry, not a liver, an appendix is ruptured, it spills that bacteria into the abdominal cavity and causes a bad infection. If they ask you what organ is in every quadrant, that would be your intestine. And if they get real specific between your small intestine and your large intestine, it would be your small intestine. Okay, even though your large intestine does pretty much hit every quadrant, but your small intestine obviously takes up pretty much space inside of it. Okay, so again, we divide it into 4 quadrants. Okay, right upper quadrant, left upper quadrant, right lower quadrant, left lower quadrant. Okay, the epigastric region.
Is there a difference between the bowel and the intestines?
Nope, just intestine is more the medical term, and your bowel is just more the generic term. So no difference whatsoever. Okay. Epigastric means above the stomach. So the only reason that's here is that sometimes when so epigastric would be like above your stomach. So, like the top of your stomach, this area up here. So sometimes when people have heart attacks, they complain of more of epigastric pain than chest pain, right? So think when somebody's having a heart attack, the pain should be where their heart is. Sometimes they complain of what's called epigastric pain, and that's just because Where you feel the pain depends on what wall of the heart is involved. So if it's the lower wall, which you know would be called the inferior wall, right? Because inferior means down. If it's the inferior wall, a lot of times people get epigastric pain, but obviously also when people have abdominal problems, they would have epigastric pain too. So that's why sometimes people having heart attack are misdiagnosed as having, you know, stomach problems when it's really the heart. And that's why we always, you know, pre-hospitally in the field kind of always say if somebody's having epigastric pain, it's always considered possibly a heart attack until proven otherwise. Okay, so again, the dividing is your umbilicus, right, or your belly button, and that's how you would divide it into quadrants. Again, diaphragm being the superior, I'm sorry, the anterior, no, superior division, right, because it's going this way, so it would be superior. Anterior would be to the front. Now, they're not going to ask you this peritoneum type of thing, but if you remember when we talked about the lungs, we said that there was a shiny covering over each lung, and that same shiny covering was also on the inside of your ribs, right? So like, remember I talked about if you bought spare ribs, bought an entire rack of ribs and turned it over, there would be that shiny lining on the inside, okay? And then your lungs also have that shiny lining on the outside of them. And those two linings actually never actually touch. Even though they're right next to each other, there's a thin amount of fluid between them, okay? And that's to allow, as the lungs expand and move, that they should be able to slide over the ribs without any friction, right? Without any pain. Okay, so, you know, that's called the pleura. So in the abdomen, they call it a peritoneum. It's a lining, okay, that is on the inside of your, like if you looked at the front of your stomach, your skin that you see, on the inside of that skin, there's a shiny lining, just like on the inside of the rib cage, there's a shiny lining. And then of course, on every abdominal organ, there's also that wrapping. Okay, so it's basically a protective wrapping. There's a thin amount of fluid so things can move around without friction or pain. Okay, so that's really what it is. Okay, so there's no, you know, big deal. They're not going to ask you names. They're not going to ask you anything, but just that it has that lining. It plays a role in protection, plays a role in anchoring everything in place, and it allows things to move, right? Because things are moving around all the time. I mean, you know, you have to realize that as you're eating food, your intestines are moving. If they weren't able to move, it would be excruciatingly painful, you know, to eat and stuff like that. So everything kind of moves around. There's actually a medical condition called adhesions. You know, when something adheres, it sticks together. So there's something called adhesions that a lot of times after people have surgery, you know, like you got to figure if you open up somebody's abdominal cavity and have to move things around, organs around, intestine around to fix whatever you have to fix, the chances of putting it back exactly the way you found it are pretty slim, right? It's very hard to do that. So sometimes after surgery, people's organs, they kind of stick. And then as the food tries to go through, it becomes very difficult. And that's called an adhesion, where they stick together. And sometimes it results in people having, you know, blockages where they can't get food through and stuff like that, and requires a second surgery. So, you know, that's kind of why those linings are there, so things are able to move around so you don't have those issues. Okay, so again, most of the organs of the abdomen are inside this lining. So the lining basically would run like this. It would come up along here. Okay, this is called your parietal peritoneum. Okay, actually it comes down over here, and you can see that the kidney, okay, is kind of snuck behind it. Okay, and then comes down and around, and everything is kind of shoved in this little space right in here. Okay. And then each organ has what they call a visceral pleura around it. Don't worry about the names, but just that it has that lining around it. Okay. So a couple of them are outside. So it says the kidneys, the pancreas, part of the aorta, the part of the aorta that goes down into the abdomen, lie in what's called the retroperitoneal space. So the peritoneum, right, was that lining, okay, and what's going on? Hold on one second. So the peritoneum is this lining, oops, right, that we said is wrapped around your abdominal cavity. And something that's behind the lining, like your kidney, is called your retroperitoneal organ. You see your aorta is behind it also, that red tube right here. Again, just for location, just so if you ever hear the term, you know, retroperitoneal bleed or retroperitoneal trauma, somebody struck from behind and stuff like that, that's what it is, okay? So there's certain organs that are in front, inside that whole that whole peritoneal space, and there's some things that lie outside of it. Once they lie outside of it, they're just more likely to be injured because they have one less layer of protection to do it. Okay, they're not going to talk about this either, but there's two different types of pain. Whenever you hear the word visceral, it always means an organ, okay? And whenever you hear the word parietal, it means the lining, the cavity that it's in. They're not going to ask you on a test, but so visceral pain is the pain when an organ has the problem, okay? So it tends to be, you know, pain that originates in the organ, okay? And it's usually not a very sharp stabbing kind of pain. It's usually like a dull, achy, you know, type of pain when it's an organ, okay? Doesn't make a huge difference for us. People are in pain, they're in pain and stuff like that, okay? It could be intermittent. They call that colic. You hear it in kids, colicky kids. You know, pain comes and goes. Intermittent means that it comes and goes and stuff like that, okay? That's typically the tubes. So like your esophagus, your intestines and stuff like that. And then solid organs like your liver, you know, your pancreas and stuff like that. That pain typically is a constant type of pain, okay? The parietal pain is the pain of the lining when the lining gets inflamed, okay? And that's typically a sharp, severe type of pain, usually caused by infection, you know, like an abscess or bacteria spilling into that, that cavity, okay? Now, the one type of pain they may ask you on the test is a patient complaining of tearing pain. And it's very interesting that this is the class that we're doing tonight, because this morning, when I got back from work from last night, I was reading the newspaper from the weekend, and they talked about Jamie Dimon. Jamie Dimon is the CEO of Chase Bank, okay? And I didn't even know this, but he had, and we're going to talk about it tonight, he had what's called an abdominal aortic aneurysm, okay? Or he actually had a thoracic aneurysm, aortic aneurysm in his chest. If it's in your belly, it's called abdominal. If it's in your chest, it's called thoracic, right? So it's still the aorta, because the aorta starts at your heart and goes all the way down into your belly. But he had an aneurysm. An aneurysm is a weakening of that blood vessel. And you know the aorta is a high pressure blood vessel. And he said basically that he was awoken from sleep with the sensation that something was tearing apart in his chest. And he called his doctor. Now, obviously, the guy's a, you know, quadrillionaire, so he probably has the doctor's cell phone. And the doctor said, you don't even have time for an ambulance. Just take a cab. You're 10 blocks away from Columbia Presbyterian. And he basically took a cab with his wife up to Columbia Presbyterian, went into the emergency room, described his symptoms. And because he talked about this tearing pain in his chest, or again, tearing pain in his abdomen, it's so classic of having an abdominal aortic aneurysm. So they actually do describe it, because what's happening with the aneurysm is the walls of the aorta are tearing. They're ripping, and that's where that bulge or weakness, it almost looks like when a tire gets a, you know, a weakened area and it gets a bulge on it. So that's what basically happens. So if it's, you know, if it's a thoracic issue, you're going to feel it towards the back of your chest. The only reason it's towards the back, okay, in other words, towards your spine, is because your aorta runs in front of your spine. So it's really, you know, to your posterior section. And if it's in your abdomen, again, it's towards your lower back. So it's basically a tearing sensation. Either if it's going to be a thoracic aneurysm, it's thoracic aortic aneurysm, it's going to be in your back. If it's going to be an abdominal aneurysm, it's going to be in your belly, but towards the back, like your lower back, okay? The term referred pain means that a nerve doesn't just, you know, it's not in just one spot, right? A nerve starts at your brain and then goes all the way through your body to wherever the organ is. So sometimes when people have pain, okay, they have what's called referred pain, which means that the pain probably starts at the organ, but travels back along the nerve, and they feel different ways. And we talked about this when we said somebody was having a heart attack. We said sometimes they get referred pain to their jaw, okay, to their back, to their, the book said to their arm. And I told you I didn't see that too often, but you know, that's all referred pain. So all it just means is that the pain is primarily where the organ that it involved is, but because it's following the nerve pathway, okay, back towards the spinal cord, back up towards the brain, you get the pain showing up in different locations and stuff like that. That's all referred pain means. Okay, so let's talk about some specific abdominal emergencies. So I would say, you know, in the course of a year, we probably get, I don't know, 24 appendicitises. So again, the appendix is an organ that we're not exactly sure what its role is. Some people feel it has some role in repopulating your intestine with good bacteria to help with the digestion of food, but we're not exactly sure. Years ago, they used to say that it was an organ left around from when we ate meat that was not fully cooked, but that, you know, that's kind of falling out of favor, but they don't know exactly what the role of the appendix is. But what happens is that sometimes, because it's at where your large and small intestine meet, sometimes some of that, they call it chyme, which is basically the partially digested food that's traveling through your digestive tract, and the digestive tract is pulling all the good things out. Sometimes some of that gets stuck in the appendix and basically causes an infection to develop in the appendix. The appendix starts swelling and getting bigger and bigger, and if it bursts, it spills all that bacteria and partially, you know, digested chyme into your peritoneal space, into the space where all your other organs are held, and it can cause a massive infection. Okay, so the most classic signs and symptoms of a appendicitis is people feel nauseous, they feel like they have to throw up. Sometimes they do throw up. They may get chills and shakes and fevers depending on how long away it is. Now the pain. Okay, so typically when an appendicitis first starts, they get what's called periumbilical pain, which means they have pain around their belly button. But then as the appendicitis develops or continues, they get what's called localized pain to their right lower quadrant. In other words, the pain, basically they find it right where the appendix actually is, in the right lower quadrant. Okay, when the appendix ruptures, which we don't want to happen, there's a sharp increase in pain as it ruptures. But then once it finishes rupturing, the pain actually goes away sometimes completely, or it gets very little, because again, the pain was caused by the appendix expanding or swelling. And once it ruptures, that, you know, that swelling goes away and stuff like that. So we don't really feel it. What is the blue color on the ribs? Let me go back. I didn't see. I didn't have.
Is there? It feels like needles, those type of pain?
No, it feels, I mean, picture being
bubbly, something.
Picture being constipated. Is this the picture you were saying about blue? Somebody asked about blue on the ribs.
Oh.
Let me see. Here? Oh, this over here? Okay, so all it's showing you is that it's not a good picture of the rib cage, because we're seeing, this is the sternum, right? We're seeing the very bottom. This is your xiphoid process. Some ribs attach directly to the sternum, but with actual bone, and some have cartilage. So the blue is just showing you the ribs that attach to the sternum, but cartilage. This is actually, sometimes people say, you know, when you do CPR on an older person, you hear the ribs breaking. But what actually is happening is that cartilage kind of creaks and makes noise when it's pressed on, like when you're cracking your knuckles and stuff like that. That's what they're just showing you there. And then remember, your bottom two ribs, you have 4 ribs. Your lower 2 ribs on each side are floating ribs, and they actually are only attached to your spine. They don't come around and attach to your actual sternum. I mean, here they're showing you many, many more as not attaching. That's just probably because they don't want to interfere with seeing the organs, but you only have 2 floating ribs, your bottom 2 ribs on each side. Okay, so somebody wrote, there's no way to describe the pain of an appendicitis. So obviously I would assume that someone had an appendicitis. It is pretty severe pain. I mean, you know, I've never had one. I mean, obviously I've taken care of a lot of patients that have had appendicitis and stuff like that, but it's pretty severe pain, but it doesn't start right away as severe pain. Okay, so it starts by basically people think they have a stomach ache or constipation, and it just continues to get worse and worse and worse. So, you know, it's, but, you know, again, the interesting thing about an appendicitis is once the appendix ruptures, pain goes away. So sometimes people get tricked and say, like, they tough through the pain, right? They toughed it out through the pain. The appendix ruptures, the pain goes away, and they say, see, I was smart not to go to the hospital because, you know, now I don't have pain anymore, so I must be better. But now what's happening over the next couple of hours, they're going to develop a massive infection, you know. So there's no way to know, you know, that you have appendicitis versus that you have constipation, right? Let's say in the very beginning. But then once the appendicitis keeps on going on, you'll notice that this is the worst abdominal pain you've ever felt. I mean, you just can't find a position to get comfortable in. So, you know, most people put 2 and 2 together that it's something, you know, more severe and stuff like that.
Exactly.
Frank, my friend had a ruptured appendix. The way he explained it to me, matter of fact, last week, he felt like abdominal pain, like strong pressure. Like it's start with pressure, like you said. He felt, first of all, he thought he's constipated. He let it go. Then it was a ruptured appendix. And then the whole problem starts.
Right. So once it ruptures, so here's the deal. If you have appendicitis, you get to the right before, and you get to the hospital before it ruptures. So let's say you get there in the first 4 hours, 4 to 6 hours, as you know, as your appendix is starting to get inflamed and get big. You get there, they do a CAT scan, they see it, and they can get you into surgery. They could do it what's called laparoscopically, which means that they make 2 tiny incisions, and they go in with cameras to, you know, see what they're doing. And they, at the end of the cameras, is actually little pinchers, little cutters, and stuff like that, and they can just snip it and pull it out. Your recovery would probably be good. Probably the most uncomfortable part of it would be is to be able to see what they're doing in there. They fill your belly with carbon dioxide, and that makes everything kind of expand. So they have room to, you know, you saw how everything's tightly packed in there. So they basically pressurize it with carbon dioxide. And, you know, then after they close you up for like probably 2 days, you feel very uncomfortable. You feel like you've eaten a huge meal and you just can't get rid of it. But now if it's at the point where it ruptures and they actually have to cut you open and go inside, you know, there's always the chance when they cut you open, because everything is, you know, so tightly packed, that they actually nip something else, right? They cut something that they're not supposed to cut. Hold on 1 second, please. I'm on call. I just have to take this call. Hello? Okay, you don't have to call me when somebody calls in sick. It's going to be a break. But yeah, just put it out. Just put it out. No, I'm going to be in the office. Okay, thanks. So, you know, basically what I'm saying is that the earlier somebody gets into the hospital, okay, the easier the surgery is to remove it. It's not going to be that they're not going to need to have surgery, but the earlier it's in, the less invasive, the less traumatizing the surgery is, and the more likely it will be that they'll have surgery without any complications. The later it gets in, the worse it is. I mean, I had probably about a year ago now, I had a paramedic came to work with, you know, the whole ride down. He lived upstate, like 2 hours away. The whole ride down, the whole day he didn't feel well. The whole ride down, he was very uncomfortable. Totally just thought he was constipated, and you know, that was that. And he came to work. They checked the truck. They went out to get dinner. He didn't want any dinner because he didn't feel well and stuff. They come back. The other guy's eating dinner, and he starts, you know, a little bit feeling sweaty, gets chills and shakes and stuff like that. And he's like, you know, he goes, either I'm having appendicitis or I got some kind of infection going on. I got to get over to the hospital. So he goes over to NIAC. They do a CAT scan. They see he's an appendicitis. Okay. And the general surgeon was already doing surgery. So they told him it would probably be, you know, this was nighttime. This was after 7 p.m. They probably told him it'd be like 4 to 6 hours before he had surgery. So, you know, again, paramedics being paramedics, everybody being a wise guy, they said, okay, let's get him out of NIAC and transfer him over to Westchester. Okay. And so they, you know, we have an ambulance come, they send him over to Westchester. He shows up at Westchester. Well, it was a busy night at Westchester. And he wound up sitting almost 18 hours before he had his appendix taken out. So if he had stayed at NIAC, he would have had it out probably 12 hours earlier. But everybody thought, you know, let's go to Westchester, it'll be quicker. It's a big hospital and everything like that. But he turned out to, you know, to wait even longer and stuff. Now, appendicitis or anything could lead to what's called peritonitis. Itis is always an infection and inflammation. So if something gets outside of the organ and into the cavity, right, into your abdominal cavity, it will cause an infection. And peritonitis is the term for a severe infection in that area. Okay, that's really all it is. You got to remember, a lot of the organs in the abdomen are very acidic, have fluids in there that are designed to break down the food with acid. Okay, and those organs can survive. They're designed to be around that high acid, but if the acid spills out of the organ into the cavity doesn't have that protective lining, so it's going to start to, tear away or eat away at the abdominal cavity and lead to infection. Now, I said before that early on in appendicitis, the pain is what they call periumbilical. So peri means around, the umbilicus or belly button. So early, before they probably know what's going on, before the pain's real severe, that's where they're going to complain of pain. That's why they think they're constipated. That's why they think it's their stomach. And then later, it localizes down to the right lower quadrant. Okay. But on the test, they're going to say to you, patient having pain right lower quadrant, what do you suspect? The answer would be an appendicitis. Okay, it would always be an appendicitis on the state exam. Okay, cholecystitis, or a problem with gallstones, right? So cholecystitis is basically a problem with your gallbladder where stones, a collection, like the enzymes that are in your gallbladder kind of join together and make almost what looks like a little stone. And there's tubes in your gallbladder that the chemicals of the gallbladder have to travel from your gallbladder, okay, down into your digestive tract. And if those stones are there, okay, they cause a blockage of it, and it's very, very painful. Okay, now if you notice that you have pain, okay, upper right quadrant pain when you eat a lot of fatty foods or greasy foods, you probably are starting to have problems with your gallbladder. Okay, when they actually have cholecystitis, which is the emergency of then they have severe, severe upper right quadrant pain. A lot of times it's referred to the upper right shoulder. Okay, so again, just referred pain. Okay, and it's usually the story will be that they ate a dinner of fatty foods and stuff like that. Again, nothing that we would do for them, even on an ALS level. All we would do is give them a little fluid, IV fluids and pain medicine, but they just need to get into the hospital. Sometimes they need to actually go in and break down those stones. They have a procedure where they bounce sound waves off of it and stuff like that, just not like with a kidney stone. Okay, same thing. Sometimes it actually involves surgery. Sometimes it's just antibiotics, depending on what the symptom is and stuff like that. Sometimes it's just pain management. It really just depends on how severe everything is. But if the gallbladder, if the tubes were actually to rupture and spill the enzymes that are being produced, then that could lead to that peritonitis. Okay, so that's where it becomes dangerous. Pancreatitis, again, remember we said your pancreas plays one role as an endocrine organ because it produces the insulin and the glucagon, the two hormones that control sugar. Okay, but it also has a role, has digestive enzymes in it. Okay, it also has a role in food breakdown. Okay, so people that are alcoholics, okay, have a high chance of pancreatitis along with liver problems. Okay, those are two big problems that people have. Okay, so again, typically epigastric pain, because remember when we saw the picture of the pancreas, it's kind of sitting right across the center. I mean, it goes on both sides, but it's kind of sitting right there in the center and stuff like that. Again, it can be referred to your back or your shoulder. Okay, GI bleeding. Okay, so now somebody has an ulcer. An ulcer is basically a weakening of the wall of the intestine. Now, we said that the intestine absorbs all the nutrients out of the food. And obviously, if it's absorbing things, that means it has to be passing those nutrients, those good things, okay, into the bloodstream so that the intestine is lined with blood vessels, with capillaries and veins and arteries. Okay, so sometimes when people have ulcers, which are erosions or weakening of the wall of the intestine, okay, they will start bleeding. Okay, so when it says hemorrhage within the lumen, means the tube. The lumen is the term for a tube. So in this case, the tube is the intestine. Okay, so people can have very minor bleeding, but it's chronic. It's happening all the time. Or people can have very severe bleeding. Obviously, it's not normal to have any bleeding. And anytime you have blood in your digestive tract, it's painful. Okay, so the blood has to go somewhere. So it really just depends on, is it an upper GI bleed or is it a lower GI bleed? So upper typically means it's bleeding from the stomach and above, lower stomach or below. Usually if it's upper, it comes out the mouth, they vomit. If it's lower, it comes out the rectum when they go to the bathroom. Most people who have GI bleeding actually have no real pain unless it's an ulcer type of bleeding, okay? So a lot of times people thought that ulcers were caused by the acid in your digestive tract eating away at the intestine. Nowadays, most people realize it's actually we have our entire digestive tract is populated besides with acid with bacteria. And sometimes the bad bacteria takes over and is stronger than the good bacteria, and that's acting on it. So sometimes when people have ulcers, the treatment actually is to give them antibiotics to suppress that bad bacteria that's growing in their tract. Now, when people have bleeding, okay, there's different types of bleeding. So dark, tarry stools, okay, frank blood, and then vomiting coffee brown. So when they say frank blood, they mean bright red blood. Okay, now that could be vomiting out the mouth, or that could be coming out of the bottom. Hemorrhoids are varicose veins in your butt. And we know that varicose veins, we said, are just dilated blood vessels that in the legs because of pressure. When you get hemorrhoids, it's because you have problems going to the bathroom and you're always straining or pushing to go to the bathroom. So this is what frank red blood would look like. In other words, there would be bright red blood either in the person's pants, underwear, toilet, on the floor, but it means that they're basically have an active fresh bleed. That's why it's bright red, okay? And it's it depends, you know, if it's upper, it's going to be coming out of their mouth by vomiting, and if it's lower, okay, it's going to come out their rectum, and you would again either see it in the toilet or in their pants or something like that. Melena, okay, is when somebody's having bleeding, okay, from the lower part of it, but it's not as fresh. In other words, it's a little older, and it's mixed with the food and the digestive enzymes. So it basically looks like a very black tarry type of stool that comes out, okay? And then old bleeding, old blood, I should say old bleeding. So fresh blood being vomited is bright red, that's frank blood. But blood that's had time to get down in the stomach and mix with the stomach contents and the acid comes out looking like coffee grounds. So when they vomit, you don't see it being bright red because it's mixing with the food that's down there and the acid, but it comes out looking like coffee ground type of material. It's not, has nothing to do with coffee or anything like that. It's just that's the look that it gives. So none of it is good, but obviously if it's this, it means it's active, fresh bleeding going on and a lot of it. Okay, here it's slower bleeding. It's had time to travel through the digestive tract and come out as poops, but you know, this specific, you know, black tarry stool type of thing that they call melena. And again, if they vomited up coffee grounds, again, it's not a lot of bleeding, but it's bleeding. It's enough bleeding that it's irritating the stomach, causing them to vomit. And because it mixed with the acid in the stomach, it gets this coffee ground type of appearance. Okay, so that's all they're looking at here. Okay, fix the word bleeding. Oh, we didn't see that. Thank you. Let's see. Oops. Okay. Okay, so now the abdominal aortic aneurysm. So basically, you know that the aorta is the blood vessel that originates off the left ventricle. And the aorta actually, the way the left ventricle pumps, it actually pumps up into the aorta, and then it arches down behind the heart, in front of the spine, but behind the heart, comes down to about the level of your belly button, maybe just a little lower, and then branches into what's called your iliac arteries that bring the blood down into your legs. Okay, and then off your aorta is every other major artery that exists to man. You see all these little branches of the aorta. So every other artery that exists in the body branches off the aorta because the aorta is the start of the artery off your left ventricle. Okay, so these are high pressure vessels. Your arteries have three walls. They have an inner wall, a middle wall, and an outer wall to handle the pressure. And sometimes what happens is that that inner wall that the blood is actually traveling up against gets a little cut in it, a little nick in it, just because of pressure, old age, you know, whatever, it just happens, okay? And the blood starts to work itself now between the middle, okay, and the outer, and there gets to be a very distinctive bulge that develops in it. So here it's down low. This would be an abdominal aortic aneurysm because that's what we're talking about tonight, okay? And it's actually right where the split is of the iliacs. A lot of times what will happen now is it'll travel down, the aneurysm will travel and cause a bulge over here. And sometimes when people have a lower abdominal aortic aneurysm, their leg goes numb because they're not getting a lot of blood down into that leg because of the aneurysm. So somebody calls you for no reason whatever, with a cold, numb leg, okay, and they're having lower pain, especially if they describe it as tearing, okay, then that's a good another story of a abdominal aortic aneurysm. Now, if the pain was up here and the aneurysm was up on this section of the aorta, then it would be a thoracic aortic aneurysm. It just depends on where it is. And you see that off the arch of the aorta, right, there's 3 big blood vessels. Here it's only showing 2 of them, but there's 3 big blood vessels, okay, and they bring blood up to your neck, okay, your brain obviously and stuff like that, and then both your upper extremities. Okay, so that's the 3 sisters, they call them. Those are the 3 that come off of that. So again, the danger of an abdominal aortic aneurysm, if it ruptures, since your aorta is your highest pressure blood vessel and your largest aorta, if it ruptures, people typically bleed to death almost instantaneously. So somebody who actually ruptures their aorta does not usually live to tell about it. Okay, so the pain of a abdominal aortic aneurysm is typically described as a tearing pain. And, you know, we always ask on a scale of 1 to 10, with 10 being the worst, they're going to tell you it's a 15, and it's always been a 15. It never changed. It's horrible. It's only getting worse. In other words, it's the worst pain they've ever really felt. Again, because the aorta runs right in front of the spine, they typically talk about it being towards their back. Now, again, if it's their upper back, it's a thoracic aneurysm. If it's their lower back, it's their abdominal. It is possible, okay, to palpate the aorta. In other words, if you're feeling the front of somebody and it's bulging, it is possible to feel it. So when they say a pulsating mass, pulsating mean like a pulsation in it, that is possible, okay? Not going to change the patient's outcome for us to find it or not. Really, it's going to be diagnosed, it's going to be by a CAT scan and stuff like that. And then the other thing that could happen is there could be unequal pulses. Again, if it's an abdominal one, it would be in the feet. If it's a thoracic one, it would be in the arms. In this article I was telling you about today with Jamie Dimon, he said that when he got to the hospital, one of the things that the emergency room doctor did right away was took his blood pressure and his pulses in both arms and noticed the difference between his 2 arms. Doesn't matter whether it's right or left or anything like that. And found that there was a big difference between each arm. So that even helped before they got the CAT scan in making the diagnosis of him having a thoracic aortic aneurysm. And they actually called the thoracic surgeons in based on that alone. And then obviously once the CAT scan came in and showed it, you know, they had 100% confirmation of their diagnosis. Okay, so the danger of the aortic aneurysm is that it actually ruptures, so that what we're looking at over here, this actually just explodes and ruptures, and the patient would bleed to death in a matter of, you know, a minute or 2 and stuff like that. The term exsanguination over here is basically the worst bleeding, right? The worst hemorrhage. Hemorrhage is another term for bleeding. So exsanguination means they bled to death. That's all it really means. So if it actually ruptures, the patient would probably die before you got there. I mean, you basically find a patient, you know, in cardiac arrest with no pulses, you know, and probably looking like they're totally pale with no blood left in them because the blood has left their blood vessels and it's, you know, filled their belly type of thing. So there's nothing really to do for those patients in that situation. You know, no matter what you try to do, nothing's going to really happen. A hernia can happen anywhere in the body, but a hernia basically means that a muscle is weakened and an organ protrudes through it. So let's take typically, where do you have hernias? Let's say your belly. So we have you have your sheathum muscle right in front of your belly here that holds everything kind of in place. And there's an area that gets weakened or gets torn or something like that. And now a loop of bowel protrudes through it, but doesn't come through the skin, right? So the skin stops it from coming through where you could see it, but it goes through the muscle. And the danger is if the muscle then grabs it, that's called a strangulation. It will deprive that piece of intestine of any blood flow, and that piece of intestine will die and rot and cause infection and stuff like that. So people can have hernias any place. They could have hernias pre-existing that are for some reason not being surgically repaired. Maybe the people don't want the surgery, or it's not big enough, or they have other medical problems and stuff like that. And, you know, they just decide it's not that big and they'll just leave it alone. Okay. But, people, this would be a typical umbilical hernia, right? This is where the belly button is. So it's just an umbilical hernia. Here they're showing like incisional hernia means that they had surgery there. And because when they cut through the muscle, the scar probably ruptured and came through. Umbilical hernia is what we're looking at over here. So there's all different kinds of hernias, inguinal hernia down towards the groin. There's all different ones, but it doesn't matter where the hernia, it matters that is the muscle that the organ has protruded through, is it now strangling it? And if that's the case, then that's a surgical emergency. So somebody's going to say, how do I know, right? Like, in other words, how do you know if it's strangling it or not? Typically, both are painful, whether it's strangulated or not strangulated. So there's no real way of knowing, right off the bat. It's just a matter of if there's somebody says, I never had this bump on my belly before, just developed, you get them to the hospital. Now, some people may say, well, maybe this is an aneurysm. Maybe this is abdominal aortic aneurysm, and it's so big that it's bulging through the skin. If it was a blood vessel, there would be a pulse to it, right? If you pressed on this and this was the aorta bulging through the skin, which very rarely happens, okay, there would be a pulse to it. So a hernia obviously is not a blood vessel. A hernia is an organ, this is probably intestine, that kind of snuck through the muscle and is trapped underneath the skin. So there's not going to be any pulse to it or anything like that. Somebody asked, why should there be a difference in blood pressures and pulses? So if we go back to here, I said that here's the aneurysm and here's your iliacs, right? So we're talking, this is where the aneurysm is. If the aneurysm starts to go down into one of the two blood vessels, there will not be good blood flow through that blood vessel. So that's why there's going to be a difference. The same thing if it's in the arch of the aorta, okay, that's where his was, this Jamie Dimon's was in the arch of his aorta, and it shuts off the blood flow to one of these two branches. Remember I said there's three big arteries that come off the arch, then one extremity will not be getting good blood flow. So you'll see a difference in between them. So that's why it happens, okay. Okay, so there's not really, again, anything we're going to do for hernias. I mean, again, on an ALS level, sometimes if we're really far from the hospital, we may give them some pain management or something like that, but there's nothing really to do. It's a surgical fix. What they actually do is they sew in a piece. So they open it up, push the organ back into place, and they sew a piece of fabric. Remember, we're looking at skin, but there's muscle underneath this skin. So they peel back the skin and they sew a piece of fabric, a very tough piece of fabric, okay, onto the muscle, and that stops it from coming through again. So that's kind of what they do. I forgot what the term of it is.
And it stays there.
It stays there. Yeah, it's called a mesh, I think.
It is called mesh, yeah.
Yeah, so it just stays there, and that's, stops it from ever happening again. When they used to just suture everything together, it used to happen again. Like here, you see it's incisional hernia. There had been a suture and it just burst through. So that's what they typically do with it. Okay, renal colic is basically kidney stones. Okay, so kidney stones are the male's equivalent of giving birth as far as a pain level goes. Women can have kidney stones. It just happens to be statistically more men have them more. But it's basically a pain that's traveling from your kidney to your bladder. So your kidney is the organ that produces the urine, right? It kind of cleanses your blood and produces urine. So after it gets all the waste product out, it starts to go through a tube down to your bladder. So your bladder is just a big holding vessel. Let's see, it was over here somewhere. So again, you see these two tubes, they're coming from your kidneys, which were, back here. They're probably like way in the back over here and here. Okay, and there's a tube that brings the urine down to your bladder. So your bladder is just a holding chamber, okay, of urine. And when it's filled or partially filled, and your body senses stretching of it, because there's nerves that rest on it, it senses that it's stretching. It gives you the sensation that you need to urinate, and you go to the bathroom. Okay, and then the fluid comes out a different tube, right, from your bladder out through your penis, or if it's a woman, out through her vagina. Now, sometimes these different, what would be the right term? These different minerals that are in your kidneys, they join together and form a deposit, like a little rock. And what the pain of this colicky is that rock traveling through this tube, trying to make it to your bladder. Okay, and that's what the pain is. And again, sometimes people pass them. They're small, they pass them, but they feel that scraping the whole time it's going through. And, you know, if they pass it on their own, they're put on a kind of a diet to prevent them from getting them and stuff like that. But if they get stuck, the problem is that they're not going to be able to urinate normally. And then they have to they break them down with kind of sound waves that they bounce off them, which in itself is a little painful and stuff like that. Or worst case scenarios, they actually have to do surgery. Okay, but that's pretty rare. Sometimes they can go in and stent open the urethra, the tube, okay, and that'll help it pass and stuff like that. If there's an area where they're more likely to get stuck and stuff like that. So it's pretty intense pain, okay. You know, it can be intermittent, which means comes and goes, because if it's traveling and it's not rubbing, okay, then it's not painful. But most of the times they have pretty steady pain until it passes and stuff like that. Again, nothing in the world to do for them and stuff like that, but get them to the hospital. There's nothing we're going to do in the field to fix them. Okay, somebody wrote, is the bulge caused only due to an, no, there's no, oh, which bulge are we talking about? So I guess we're talking about the abdominal aortic aneurysm, not the hernia. On this one, Mordecai? Okay, yes. Okay, so he's saying, is the bulge caused only due to, no, it's not an embolism. The bulge is, so, okay, so let's go back to, so this happens for, say, I don't know, 3 or 4 different reasons. It could happen because the pressure in the aorta is great, too high, okay, and it just overstretches or weakens it. But most of the times it happens because, again, it's hard to see it, but there's 3 linings to the wall of an aorta. And the inner lining sometimes is the one the pressure of the blood is against all the time. And it just gets a little area that's weakened, and the blood starts to work its way into that little weakened area. And you know what? Let me find a better slide. Hold on for 1 second. Okay, can you see the new slide? Gastrointestinal bleeding abdominal aortic aneurysm. Can you see that? Yes.
Yeah.
Okay.
Yeah.
So this is a CT angiogram of the aneurysm, right? So this is the aorta. Here's your kidneys, okay, and this is the aorta. Here's your iliacs, and you can see that it's kind of starting to dissect down into the iliac. So I assume this guy's left leg is probably getting numb and stuff like that. So this is, you know, a pretty good view of actually what's happening. Now, sometimes, okay, it can be so severe that you actually see a bulge through. So this is the guy's CAT scan. You see the bulge. But again, this would have a pulse to it because it's the aorta, where the hernia, again, would not have a pulse on it and stuff like that. Now, it's a little hard to see, but this is the arch of the aorta, right? So the left ventricle pumps up, comes down behind the heart, and then goes down into your abdomen, right? And becomes your abdominal. And then this is the 3 blood vessels. So if you could see, what they're pointing to over here is that there was a small little nick that developed on the inside. Now the blood is splashing through here, right, under high pressure. So what happens now, if you notice, is that it's starting to tunnel between the inner layer and the other 2 layers, and it's peeling it away, right? Now, if that peeling away continues past this blood vessel, then that guy's going to lose pulses in his right arm. His blood pressure is going to be lower, okay, and his pulses are going to be weaker in his right arm. Again, if it was down here and it was doing that, then it would be the legs. So what's happening now is blood is tearing away. It's ripping its way through. This is where the bulge is going to develop now, because this layer here is not doing anything to keep the blood in place anymore. So this is the area where the dissection is, the aneurysm is, and it could rupture. The other thing that could happen is that there's blood obviously spilling up in here, but it's not actually flowing like it's flowing in here. So anytime you have stagnant blood flow, there's always a chance of a clot developing in here. So now some fresh blood pushes this clot out, and it travels up into the bloodstream and goes somewhere and causes, you know, an embolism somewhere else. But the actual aneurysm that you first see is just because, again, there was a little weakened area in the aorta, and because the aorta is a high pressure vessel, it started to wear away at it and tear away at it, and it turned it into this weakened area, and it gets that distinctive bulge, which is called the aneurysm. Okay, so is that a good explanation? Okay, let's see if we can go back and find where we were. Okay. Okay, so we talked about kidney stones. Now, just cardiac. It's not that when you're having an abdominal problem, the heart is causing it. But what just to realize is that people who are truly having a heart attack, okay, can complain of more stomach symptoms than heart problems. And it's really their heart that's the problem. And it just depends on the wall of the blood vessel. I'm sorry, the wall of the heart that's involved. If it's the lower wall that sits right above, okay, their belly, they're going to have what's called epigastric pain. Epi means above the belly, above the gastric area. And it's still their heart. It's just that it's the bottom part of their heart, and it gives them, you know, those symptoms. It's called an inferior wall, inferior meaning to the bottom, inferior wall of the heart, you know, heart attack. And a lot of times people complain of more stomach symptoms. You know, it's my stomach. I must have eaten something that bothered me, but they're actually having a heart attack. Okay, so that's why, again, there's not a 100% way on a BLS level you're going to be able to know. So we always err towards the side of caution. And if somebody has abdominal complaints, we're always going to assume it's a heart attack. Okay, as far as treating them, that's kind of a judgment call. If you really think it's a heart attack, then by all means you can get and give them the aspirin and stuff like that. But usually I would say call medical control, describe the signs and symptoms, and ask them if you want to go ahead and give them the aspirin. Most times oxygen is going to be fine, stuff like that. But if you want to give them the aspirin, or you want to just, you know, transport. Okay. Okay. So there, when we're talking about like what we're going to do and stuff like that with them. So there's so many different reasons why somebody can have abdominal pain that it's impossible for us in the field to be able to figure out exactly what their organ is going to be. So again, really what it is get them to the hospital. I mean, put them on oxygen, make them comfortable, get them to the hospital. A lot of times the only reason they're calling the ambulance is they're in such pain that they can't actually get out of their house to go to the hospital, and they need somebody to carry them and stuff like that. Okay. Again, scene size up and stuff like that, whatever, you know, I mean, you know, we're always concerned about fluids and blood and infection, stuff like that. So there's, you protect yourself appropriately, you're not going to have an issue. Again, I don't know of any specific odor that's going to key you into one emergency versus the other than, you know, abdominal emergencies can be smelly, okay, and stuff like that, but there's no way of knowing. And again, is it a medical issue or a trauma issue or a combination of both, right? So sometimes, very rarely, most of the times we're talking about abdominal conditions, non-traumatic abdominal conditions, they're medical in origin, right? I mean, it's different than somebody who was hit by a car, fell off a ladder or something like that, okay? Oxygen, again, probably is not going to change their outcome. You know, you can be pretty much guided by their pulse ox and stuff like that. If it's above 94%, they probably don't need supplemental oxygen unless you think it has some psychological benefit for the patient that they feel like something's being done for them or something like that. I mean, you're not going to hurt them, but there's probably no benefit in giving them and stuff like that. Remember your OPQRST as a way of, you know, asking the questions to help you do it. So onset again, you know, what were you doing when it happened? Okay, when did it begin and stuff like that? Provocation, does it anything make it better or worse? Palliation is making it better, relieving the pain. So does anything make it better or worse? Okay, quality, can you describe it? Again, on the test, It's going to be the tearing pain question of the abdominal aortic aneurysm. Okay, show me where it hurts. Okay, does it travel anyplace else? Okay, severity on a scale of 1 to 10, with 10 being the worst. How bad is the pain when it started? How bad is the pain now? And if you do anything to them, does that change the pain at all? Okay. And time, again, when did it start? Has it been constant? You know, anything changed with it when you treat them? Has anything helped or anything like that? Certain things with female patients, again, that you may, you know, again, in the Jewish world, it's going to be a little hard to ask these questions. They're probably not going to answer you and stuff. But again, could you be pregnant? Okay, is the big question that we always ask. Okay, and you know, you could ask, did you miss your period and stuff like that? You know, and stuff like that. You know, is it normal for you to have some bleeding and all those kinds of questions? But again, in the Jewish world, you're not going to really be, you know, asking them nor getting answers to them if you do ask them and stuff like that.
The O on the O from the OPQRS.
Mm-hmm.
The on time.
Onset.
The onset. Okay, what is the difference? What's the difference between onset and time?
Nothing. Onset, I mean, to me is, I would say onset is what were you doing when it happened? Okay. But people also use it for when did it happen and stuff like that. The time, okay, I usually would say, how long has it been going on? Is it constant and stuff like that? So to me, onset is like, what were you doing when it happened? And a lot of times people are going to say, I was just sitting there. I was doing nothing, right? I mean, the average heart attack is, you know, I was just sitting here. I was asleep. You know, there was no, we think it's exertion with a heart attack, but it's not. When it's pain brought on with exertion, a lot of times it's angina. It's not the actual heart attack. Okay, so onset, I would say the easiest thing is, you know, what were you doing when the pain came on? They're not going to ask you to pick one or two of these like on the test. They're going to say, a lot of times they'll just say the O of onset, you know, means, I'm sorry, the O and OPQRST means what? And then they'll have, you know, onset, outside, other, you know, they'll have some like stupid words to try to trick you and stuff like that. I think I actually put one of those questions on one of our quizzes. Okay. And again, even if we're asking someone if they're using birth control, which again, in, you know, your population, you're probably not going to be asking, does not mean that they can't be pregnant. Just because somebody's on birth control, they can still get pregnant. I mean, the likelihood is less, but it still can mean that they got pregnant. Okay. Again, your history, you know, your amples, right? Your allergies, medications, pertinent past medical history. Pertinent means that it has some kind of role in what you think is wrong with them. But I would say, I would ask about all past history. Okay. I would even ask about, like, if you were leaning towards a hernia diagnosis, an important past history would be, have you ever had any surgery, you know, involving your abdomen? Okay. Last food, right? Last oral intake, okay, and events leading up to the emergency, which is kind of like the onset, right? So the E here is kind of like the onset, okay. With older people, with geriatrics and stuff like that, okay, just remember that as you get older, right, your nerve endings that give you the sensation of pain start to break down. So you don't feel pain as early, which means that they're going to have their symptoms later, okay? And it's going to be a little harder to figure out what's going on. Also, they may be on medications that they're taking for other conditions that will either mask the pain or make them more likely to have an emergency. Okay, so there's a lot of other things that can be going on with geriatric patients. As far as the decreased sensation of pain, remember also the diabetics are in that same boat, right? So geriatrics, older people, and diabetics. And older people, just because their nerves are older and not working as well. With diabetics, again, because the disease of diabetes interferes with the blood flow at the capillary level to the different, you know, parts of your body. So if you're not getting blood to different parts of your body, your nerves are not going to work properly and stuff like that. When we're doing our physical exam, again, we're going to inspect, which means we're going to look. Distension means swelling. Do we see any swelling on the abdomen? Any bruise or discoloration on the skin? Protrusions like the hernia, something coming through the body. Okay. Palpation, we're going to feel the belly and see if we have any pain. If they tell you they have pain, there's no reason to palpate it. I'll just tell you that's stupid. In other words, if they're telling you it hurts right here, then there's no reason to palpate it and increase their pain. The only reason we palpate is if somebody says they have no pain. We want to see if we can trigger any pain by pressing on the area. So, you know, but once they have pain, there's no purpose other than, you know, pissing them off. There's no reason to palpate and stuff like that. Okay. Whoops. What happened here?
How about palpating the other places?
So if somebody was, let's say you show up and somebody's holding their right lower quadrant and they say to you, I'm having terrible pain in my right lower quadrant. Okay. And they're guarding it, which means they have their hands over it, right? Because when they hold it, it doesn't hurt as much. So what I would do personally is I would say to them, does it hurt anywhere else? Yes or no? And if they say yes, you tell me where else does it hurt? Okay. Does it hurt as bad as your right lower quadrant? No, not quite as bad. Okay. Again, it's not going to change the patient's outcome, and it's not going to change what you're going to do for them to palpate their belly. The only time you really usually will get something out of palpation is if you have an unconscious patient and you don't know what's going on, and you press in places and all of a sudden you hear them moan, then you can kind of figure out that maybe something's going on over there. So, palpating on a conscious patient already tells you to have pain, serves no purpose other than to, hurt them more. And so there's no real purpose in doing anything like that. Again, on an unconscious patient, by all means, or maybe somebody who's not 100% with it, okay, palpating may play a role or something like that, or but once they tell you there's pain there, especially if they're doing what you see down here where it's saying guarding, where they're actually kind of self-stabilizing it, holding in place themselves, there's nothing to be gained by it. I mean, it may look like you're, I don't know, doing something, but there's nothing medically that's going to be really gained by it or anything like that.
Loud and clear.
Okay. Okay. So any questions on the abdominal aortic? On the exam, it's going to be appendicitis, right lower quadrant. I'll just tell you, that's the main question they ask, on the state exam. Okay. So let's take, what time is it now? 9 o'clock. Let's take, it's 9:06. So let's come back about 9:20. And we'll do the behavioral, and then we'll call it a night. Okay, let's take a little break. Okay, so let's finish up chapter chapter 23. We'll finish it tonight, and then we'll call it a night. Okay, so the first thing to realize is when we're dealing with behavioral emergencies is that we don't have any training. We're going to spend half hour, 45 minutes on it. We don't have any real training in dealing with these patients. For the most part, usually are not dangerous, but there is always the potential where they could be dangerous. We do in this county have a behavioral health response team that is in service until midnight. And then from midnight to 8 a.m., they're available by phone. So if you did have a psychiatric patient that wasn't violent and you had time to kind of diffuse the situation, you can call them to come and help and guide you on what to do if the patient needs to go to hospital, or if they can be treated on an outpatient basis and stuff like that. The police usually reach out to them and have them come and stuff like that, but anybody can summon them to come. But we just don't have enough time or even if we had time to talk about it, we don't have enough hands-on experience to be able to deal with this. So it's, it's something we talk about in class, but it's not something really that, you shouldn't feel that you have any real expertise in or anything like that. Okay, so there's no difference between behavioral versus psychiatric. They're used kind of interchangeably, although when they say psychiatric emergency, they tend to be more serious ones that can present, with dangerous behavior or violent behavior and stuff like that. There's a lot of different things that could trigger it, okay? And just remember, sometimes people appear to be having strictly a behavioral psychiatric emergency, but there's actually a medical reason why they're acting that way. Like tomorrow night, when we talk about diabetic emergencies, we're going to see that when people's blood sugars go low, they act in very strange ways. And sometimes people mistake that as actually having a behavioral issue, which is why whenever we have a patient that we suspect of having any type of behavioral psychiatric, we don't transport them directly to a psychiatric hospital. We always have to take them to a regular hospital to get them medically cleared to make sure there's no medical reason why they're acting that way, because a psychiatric hospital does not have any ability to treat medical problems. Okay. So again, when we talk about behavior, we talk about how people should perform, how they should act, how they perform around other people and stuff like that. And when you're saying it's a behavioral emergency, is that the way that people are acting is not an acceptable behavior given the social norms, in other words, the environment they're in and stuff like that. And remember, what we may think is acceptable in our community may be different than what people think acceptable in other communities and the other way. So there's definitely some leeway You know, I mean, you could go into a place where every other word would be, you know, profanity, and that's just the way they communicate. But to a place where they're not used to using a lot of profanity, that may be, you know, an unacceptable behavior, right? So it's just everything. Everything is different, you know, different depending on, you know, what you're used to and stuff like that. Okay, so there are some specific psychiatric emergencies, obviously. Okay, so anxiety means that people are very anxious or worried about things. Okay, panic means that they actually get to the point where they can't function over it. So one thing to be a little bit of a nervous person, but we're at a point where you can't actually leave the house because you think there's things out there that are going to get you, or, you know, something like that. So there's definitely people who have that. Okay. Depression, obviously, I think everybody knows what that is. Now, bipolar means they go both ways. So at one point, they're very hyped up and happy and bouncing all over the place. And then the next minute, they get depressed. So when they say bipolar, they mean they go both ways, right? So it's also used to be called manic depressive. Manic meaning very excitable, and then depressive meaning very quiet. So bipolar kind of goes both ways. So somebody could be just, you know, just this, or they could have it going in both different ways. Schizophrenia is a very, very sad situation. Most people that are schizophrenics actually were normal for probably the first anywhere between 15 and 25 years of age. And then something happened, and there's no rhyme or reason what happened, but they are no longer, I don't want to use the word normal anymore, but they're no longer the same person they were before they have this schizophrenic event. Now, sometimes it could be because of severe mental or physical trauma, but sometimes it just happens and stuff. So we'll talk about all those things as we go on. Now, like I said before, remember, it doesn't have to be a straight psychiatric problem. There could be a medical or traumatic reason why they're having it. So we talked about low sugar, well, you know, low oxygen, anytime the brain's not getting what it needs. Okay. It could be because of medical problems like a stroke, which is kind of like a heart attack in the brain where the brain's not getting enough blood. It could be because of trauma. Okay, it could be the drugs they're taking, or it could be because they're too hot or too cold, right? They're in too hot or cold an environment. If you've ever seen somebody burning up with a fever, right, a lot of times they're not making any sense because their brain is at too high of a temperature, it's not working well and stuff like that. So I had a guy one time that was having what we call heat stroke, a true heat emergency, where basically he was burning up, and he had fought in the Second World War on a submarine, and he was talking as if he was still on the submarine. This is, you know, 30 years after the war was done, and he was talking like he was on the submarine because, as I guess his brain was cooking. For some reason, those were the words that were coming out of his mouth and stuff like that. So there's a lot of different reasons why people can have what they call an altered mental status, a non-normal mental status, right? They're not acting appropriately. And it doesn't have to be a true psychiatric emergency. It could be a medical etiology. Again, this is why we don't transport people directly to psychiatric hospitals, right, from the field. They're always going to go to a regular medical hospital and then go on, okay? Okay, in stressful reactions, it's normal for people to be angry. It's normal for people to be fearful, right? To be sad. You remember there was that test question that said, you know, I forgot exactly how it worded, but it's talked about the stages of dying when somebody doesn't accept the fact that somebody died, and they, you know, you tell them the patient passed away. What is that called? And it's called denial, right? So there's usually on every state exam, there'll be one question dealing with this. So, you know, if you tell a family member that their loved one died and they get upset with you, that would be anger. You know, if they start crying, it would be grief. So, you know, there's all different, if they won't accept that he died, you know, that's denial. So there's all these different situations. And again, these words are hard a lot of times because people don't use them, you know, on a regular basis, but we'll be going over, you know, starting probably this Motzei Shabbos, we'll be going over lots and lots of test questions. Oh, by the way, I apologize for last week. I got called into work, and it was just so crazy that I didn't even have a second to send out anything to let anybody know. I apologize. But I'm not going to be, it can't happen to me again this Saturday, so I'll be available this Motzei Shabbos. So, okay, so, you know, when people are having these types of, you know, reactions, whether it be stress, whether it be grief, whatever it be, you know, it's basically listening is what it really comes down to with this is, you know, they want to be heard, just listen to them as best you can and stuff like that. You know, and try to give the appearance, even if you're not so interested, try to give the appearance of being sincere and interested and stuff like that, you know, to the patient and stuff like that. Okay, so schizophrenia is what they call psychosis. Psychosis is that the patient's mind is not there, right? They're not following what's going on that everybody else sees, everybody else is following and stuff like that. So they can't really interact, you know, with people around them, the environment around them and stuff like that. So the worst manifestation of a schizophrenia. You know, and what happens basically is they'll see things. Hallucinations means they see things. Okay. Delusions, they think things. Catatonia means that they're in a catatonic state. In other words, you could be waving your hand in front of them and they don't even respond to you or anything like that, right? So there's a lot of different ways, you know, they're not thinking clearly and stuff. Now, these are patients that could be totally withdrawn and, you know, have nothing to do with you. Okay, or patients that could be very violent, or they could be very withdrawn to start with, and then something triggers them to become violent. So I'm not saying that they all have to be, you know, tied up and restrained and everything like that, but you just have to have in the back of your mind that they're probably not mentally, you know, with it, and that anything could happen with them. So you just want to make sure that you have enough people, that you're protected, that there's no chance of them picking up any kind of weapons, whether even if it be a kitchen where there's knives and scissors and stuff like that. Okay. So when people present, it could be a lot of different ways, right? They could be withdrawn where they're not communicating with you. They could be very talkative and agitated, not necessarily making any real sense. They could be having threatening, bizarre behavior. They could be a danger to themselves or others. So once somebody becomes that where we think they're a danger to themselves or others, that's where if the police are not already involved, we have to get the police involved, because it can be to the point where that patient's going to have to be restrained and transported to the hospital. It is best if we do not make the decision or carry out the process of restraining a patient, because again, that's where the whole legal problems come in, right? You restrain somebody who really didn't need to be restrained and stuff like that. So it's better to have the police involved. It's better for everybody that's there to be on the same page. Than you to decide to restrain that patient and then call the police, and then the cops are like, well, why'd you restrain him? You know, like we don't see anything wrong with him. And then the patient picks up on that and says, you know, I want to press charges against them. So I never, ever restrain someone without having the police present or anything like that. Okay. When you're dealing with patients that are having behavioral emergencies, make sure you say, we're not the police, you know, we're the paramedics, we're the EMTs, we're here to help you. What can we do to help you? Again, keep an eye contact with them, make sure that they think you're sincere, that you're concerned about what's going on with them, you know, speak in a way that they can understand, try not to use medical terms and stuff like that. Again, listening is the big thing. And for those of us that don't have this, you know, social work, behavioral emergency background, just sitting there and listening to somebody who probably is not making much sense and appearing sincere about it is a very hard, you know, trait to develop. It's very, you know, people who can really get across and deal with these situations, you know, have a true gift. It's very, very, very hard and stuff like that. Okay, try not to be judgmental, right? Try not to take, you know, sometimes you'll have parents involved or you have a spouse involved and stuff like that. Try not to take anybody's side with it. Okay, watch your body language, like staying like I am with your arms crossed all the time and stuff like that is taken as a, you know, either being aggressive or being bored. So, you know, try not to give any kind of body language signal out or anything like that. You can acknowledge what the patient's feelings are without actually agreeing to them. In other words, if the patient says to you, I don't know, do you see the elephant in the room? You could say, you know, no, right now I don't see that elephant in the room, but I totally understand that you do see it. Okay, you know, but right now I don't see it. So you don't have to necessarily agree to everything they're saying, but you at least acknowledge what they're saying, or, you know, that they're,
Validate.
yeah, you know, or that, you know, they seem to be getting upset about something that in your mind is not such a big deal. You know, I mean, like, I'll give you an example, like, you know, we'll go on calls where, I don't know, the parents have the kids have a problem with the parents, or the parents have a problem with the kids. And sometimes it's over school. And, you know, it's whatever, they're not doing their schoolwork, they're not doing this, they're not getting good grades in school or something like that. And, you know, so obviously in somebody's mind, it's a big deal, right? So, you know, you got to be careful with saying, like, you know, listen, you know, maybe this is not worth having the police and the ambulance and everything coming to the house because the kid won't do his homework. You know, you just have to be careful, like how you do it and stuff like that, because you can turn one, you know, the kid will say, see, I told you. And then the parents will be like, well, why are you taking his side? And then now all of a sudden we're in the middle of this whole family situation and stuff like that. Okay. What else? Okay, again, make sure this I'm real big on. Like, I don't like people getting close to me, and I assume people don't like me getting close to them. So I tell everybody, I always say to people, listen, there's a state law. There's not, but there's a state law that says we have to stay at least 5 feet away from you. Right here it says 3 feet, and that that gives you some space from the patient and stuff like that. And once you say it's a law, we say, listen, we're not allowed to be closer to you than 5 feet. And people, oh, okay, and they tend to buy into that and stuff like that. Okay. Be alert for changes, right? Somebody may be calm and then all of a sudden not be calm. So be alert. Okay. Again, restraints. I would always have the police involved. Okay. So here they're showing you that to safely be able to restrain someone, you have to have at a minimum at least one person for every extremity. I would say not even to think about trying to restrain someone, to you having a overwhelming show of force. Because sometimes if you have so many people and so many big people, the person will just decide that it's not worth fighting, right? It's just it's not worth it, and they'll just be cooperative and stuff like that because they know there's no way really to win the battle, so to speak. We had a patient one time that had orders to be committed. In other words, they were being forced to go to a psychiatric hospital, and they did not want to go. And they said, there's no way they're going, and that's it. They're not going or anything like that. So, we waited. Eventually, there were like 5 or 6 cops and the 2 paramedics, the 2 EMTs. So there was like, 10, 12 people in the room. And I said to him, I said, Joe, listen, it's going to go down one or two ways. I said, you got a bunch of neighbors outside your house. I said, so let's do one or two things. I said, either you could fight with us, and we're going to basically wrestle you to the ground, tie you up, and drag you out on a stretcher to the hospital looking like a screaming crazy person. And your neighbors are going to see that. Or you can sit on a stretcher, okay, and hold your stomach and go, ow, 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 and say that your stomach hurts and you're going to the hospital because you have stomach ache. And nobody's going to know that you're being committed to a psychiatric hospital, because they think you're going to, the hospital because you have a stomach ache. And when you presented it to him that way, he was kind of like, okay. And he basically, got up on the stretcher, they wheeled him out to the ambulance and, took him to the hospital. And we told him, I said, listen, if you play games, or anything like that, then it's going to go the other way. And he cooperated. But there's some patients that are not with it enough to make that kind of decision, and you may have to restrain them. But again, we don't restrain without the police present, and we don't restrain until we have like an overwhelming, kind of show of force to be able to restrain it. And we'll talk about restraining in positions and stuff like that in a second. Okay. So just remember, suicide is another issue that we deal with. Obviously, it could be suicidal, they call it ideations, where they're verbalizing or maybe making some superficial threats, like, making minor cuts on their arms and stuff like that, to actually carrying it out. Okay. They say that women talk more about it, but men are more successful at it. As far as ages go, most people commit suicide between the age of 15 and 24, they said here. I mean, I think it's probably maybe a little higher than 15. I haven't really seen a younger kid in a while do that. Most of the ones I see, what I would say probably are more like, say, 17 to like 30 something, men more than women. Okay. There's definitely an increase in suicide in older. There's definitely been an increase in suicide with COVID. There's been more behavioral emergencies and stuff like that with COVID, just because people are stuck in the house and around family members they don't necessarily like and stuff like that. So, that's all there and stuff like that. Again, we don't have to get into it. If somebody, if somebody is telling us they feel like they want to hurt themselves, that's enough. We don't have to get into why they feel like they want to hurt themselves. But, it's just once they say that, it's enough that they have to go to, again, a medical hospital, get medically cleared, and then they'll go to a psychiatric hospital and stuff like that. Okay. Things that make it more convincing that they're going to do it is they actually have a plan on how they're going to do it. They've assembled the equipment they need to do it and stuff like that. Okay. People have made previous attempts and threats. Okay. That would also make it a little more do it. And when they're saying sudden improvement from depression, for some reason, when people have depression and they're put on medication to control their depression, for the first probably 30 to 60 days, first month or two, the rate of suicide increases. So you would think that, like, you know, they're on medication, they're getting better from the depression, their chance of suicide would go down, but it actually goes up a little bit. I'm not 100% certain if it has something to do with the medication, you know, what it has to do and stuff like that. But there definitely is, like, when patients are put on, and this is more younger kids, but when patients are put on antidepressive medications, they actually have to be followed very, very carefully, and usually involves, you know, pretty much being in contact by phone and in person with the prescriber of the medications on a, you know, quite a, like the day after, it's like twice, then, you know, maybe once a day for the next week or two. It becomes, you know, it's very, they really have to be in contact with it because there is a high chance of it and stuff like that. Okay. Again, you know, scene safety is always important and everything like that. I wouldn't get involved in restraining until the police are involved and stuff like that. Here they're talking about, you know, consider clues that the situation may be dangerous based on dispatch information that you get, things you may hear as you're pulling up, okay, information you get from family. In other words, you don't want to enter into a house that could be potentially violent. You'd be much safer on the outside of the house than walking into a room with someone. So you try to see whatever you can. Always have an escape route in mind. Don't let the patient get between you and your escape route. In other words, you and the door and stuff like that. Again, no threats to the patient. Try to keep them out of rooms where there could be weapons. Try to see if you're going to, once you do restrain someone, you always want to pat them down to make sure there's no weapons on them and stuff like that. Okay. A reasonable force. Whenever you restrain someone, the legal term is you're allowed to restrain them by using reasonable force. So reasonable force is the force that would be enough to restrain the patient with very little chance of harm to them. Okay. And, you know, that's something that you can't, it would only come to play if something went wrong, so to speak. You know, I mean, in other words, you can't look at someone and say, okay, this is the amount of force I need to restrain them, because you don't know how they're going to respond to you wanting to restrain them and stuff like that. But always the minimal amount and stuff like that. Okay. Again, I wouldn't restrain someone without getting the police involved. Okay. And that's only, again, to protect you legally from being charged and stuff like that. Now, this is the thing that we face now. Now, you've seen the situations that are happening where the police are trying to restrain people being arrested and the patients die in the process of being restrained. Okay. So this is a condition called excited delirium. So obviously everybody knows what excited means, but delirium means they're delirious. They're not making sense. And it usually involves people who have some psychiatric problem and they're abusing drugs. Specifically, the drug they're usually abusing is cocaine. And what happens is that in the process of trying to secure them to be arrested, the patient goes into this very hyper state where their blood pressure gets very high, their breathing gets very fast, their pulse gets very fast, and their temperature, you see it says here hyperthermic, that means high temperature. They get very, very high. And there's patients who actually go into cardiac arrest in this situation. So this is why now the police are going towards like less physical means of trying to like de-escalate the situation without getting to physical means of doing it. Now, there's a term called positional asphyxia. So positional means the position they're in, asphyxia means they can't breathe. So what they're finding, and this is what you see, you know, a lot of this stuff with the people dying when getting arrested, is that the cops are taught to restrain someone in a face down position to get control of it, right? That to put them in a face down position. When the patients are in this state of excited delirium and they're put in a face down position, they can't, their tidal volume, the amount of air they're bringing in and out becomes very minimal. They can't breathe well when they're in a face down position. And, you know, this is how they basically die. And this is the, you know, the same thing you're hearing with people kneeling on patients' backs, kneeling on their necks, the cops, when they're the patient's in a face down position. Patients can't breathe when that's done. They can't expand their chest wall enough to get air in, and they go into respiratory arrest and die. So we cannot transport patients, even if the police have handcuffed them, because they're so violent and dangerous. We cannot transport them in a face down position. Okay. Because it's just so highly dangerous for them. Now, again, you don't have to do anything that's going to put your life in danger. You don't have to argue with the police. I mean, if the police are forcing you to transport in a face down position, I would say to them, you know, you need to come and you need to be in charge of that patient. And I'm just pointing out to you that it's a very dangerous way of transporting them. And, you know, we're going to document that you basically forced us to transport them in that position, because you've seen it. You can see videos, you know, on YouTube, videos on the news of patients basically being arrested by the police in a face down position and dying. It's not an uncommon thing. The cops are really getting away from it now, obviously, because of, you know, all the riots and the Black Lives Matters and the this and that, everything that we're seeing. But the long and short is that really most patients do not deserve to die because they did something minor wrong and they're getting arrested, even if they're resisting arrest, right? I mean, you know, if you see some of this stuff that people have been killed over, it's the silliest of silliest types of crimes. It's not like they're out there killing people or anything like that. So there needs to be a whole change in the police training, the police, you know, philosophy of arresting people, and what and who needs to be arrested, and what do you do when people are resisting being arrested, right? I mean, even the use of non-lethal force like tasers has side effects, right? Spring Valley Police tasered somebody last summer and killed them. So, you know, and they're trying to keep it all under the, you know, under the cover and stuff like that. So, you know, it's just it got excessive, and now it's all out there, and now they're trying to react to it and stuff like that. Okay, so again, restraining a patient should involve the police. Okay, make sure you have enough people. Okay, don't start the process. Okay, until you have everybody assembled, and also very importantly, everybody knows their roles, right? I mean, you don't want to just charge in there without everybody knowing what they're supposed to be doing and stuff like that. But once you make a decision and you enter, you just do it, right? You don't then try to, you know, have a discussion and stuff like that. Once you've reached a point where you decide the only thing to do is restrain someone, you get enough people, you discuss amongst yourselves how you're doing it, and then you enter a room and you just do it. You don't give them time to react or anything like that. Okay. While the patient is being restrained, if somebody, usually we try, if it's a male, to have a female EMT, talk to the patient, try to calm them down and stuff like that. Obviously, you need at least one person for every extremity to be able to do it. Sometimes you may even need more and stuff like that. Okay. We don't have leather restraints on the ambulance, so most of the times we usually depend on the police to handcuff them and stuff like that. And they should always be on their back. Okay, never face down, never prone, right? We said and stuff like that. Okay, you have to always be watching their airway, watching their breathing, making sure there's no problems and stuff like that. If the patient's spitting and coughing, you can put a surgical mask over them, or you could put a non-rebreather on them or something like that. A non-rebreather looks better because at least you're giving them oxygen and stuff like that. And you just have to watch that they don't go to sleep, right? They don't get quiet, they don't go to sleep, because that could mean they're having problems. But you also have to have in the back of your mind that they may be faking and pretending to be unconscious just to get you to untie them, right? So it's a tough situation to be able to, you know, tell the difference between that. And that again comes with time and, you know, time and experience and stuff like that. Okay, appropriate facility. Okay, so again, as far as we're concerned, all psychiatric patients have to go to a medical hospital. So for us, it's going to be Good Sam or Nyack to rule out, okay, whether or not there's a medical reason they're acting that way. And then they will make arrangements to transport that patient to a psychiatric hospital if that's what they need. So we don't have to worry about getting in that stuff. Again, as far as our risks from a medical legal standpoint and stuff like that, okay, having a patient having a behavioral emergency, refuse care and sign an RMA and leave is very dangerous, because, you know, what happens if they walk out onto traffic, or what happens if they do something? So again, we try to get the police involved. With restraints, we're always getting the police involved and stuff like that. There is a law in New York State called the mental hygiene law, which allows a patient to be restrained if they're a danger to themselves or others, and could be forced to go to a hospital against their will if they're a danger to themselves or danger to others. But again, just to minimize our risk of lawsuits and stuff like that, we usually want to have the police involved, so that, you know, because they're the people that are going to take the other side if, you know, if we don't have them involved. So it's best to have them involved from the beginning and stuff like that. Be very careful having male EMTs in the back of an ambulance with a female patient. Okay, so, you know, that's just a recipe for disaster. So if there's no females on the crew, okay, then try to have a female police officer or somebody that's a female in the back of the ambulance. I would not transport a female patient in the back of an ambulance without having a female, you know, EMT present when you're dealing with behavioral problems and stuff like that. We even had a situation where a girl acted out in school, and the school called the police. The police said, okay, take her to the hospital. The mother went into the front of the ambulance, and the girl and the male EMT were in the back of the ambulance. And the mother made allegations that she was looking from the front of the ambulance to the back of the ambulance, and that the EMT was touching her daughter in an inappropriate way. So what you're going to see happen, and it's a lot of places have it already, is not in Rockland, but in all other places, there's going to be cameras recording in the back of ambulances. It's probably the safest thing to do. Have voice recording and video recording in the back of ambulances. And all you have to do is put up a sign saying that, you know, that everybody can see that there's audio and visual recording going on, and then you're allowed to do it. So it's probably a great idea. I'm all for it type of thing. Okay, so any questions on anything we went over tonight, or any questions on anything that we talked about so far in class? I gave David Floor a printout of everybody who took the exams and passed, and everybody who took the exams and didn't pass, and everybody who didn't take the exams. So he's going to be contacting people. You have to get those exams done to be able to finish class. You also have to get your FEMA paperwork, your ICS classes done, your hazmat classes done. You know, all those things are state requirements. We had to give you tests, you know, during class and stuff like that. I'll probably make one more test before the end of class, just after we finish diabetes, going over the last few things and stuff like that. Remember, the tests are there for you to kind of get an idea of what you need to review. Saturday night, you can let me know if you want to go over tests I made, or you want to go over test questions that appear on the state exam, whatever you want to do. But we're going to start, you know, concentrating on getting the terminology down so that when you see the questions, when you're taking the exam, it won't be the first time that you're seeing it, and you'll be able to understand it and answer the questions appropriately and stuff like that. More than likely, your state exam is going to involve you going to a testing site and sitting in front of a computer and taking the test. It's not going to be on paper. So you have to get into the habit of, you know, taking tests on computers and stuff like that, so you don't get nervous and you're able to answer everything. Okay. Any questions? Anything else? Okay, so everybody have a good night.
Is it going to be, by the testing net, is it going to be immediate answer, pass or fail?
That's a good question. I don't know. I heard that you do get results immediately, but then somebody told me the other day it took like a week or two to get the results. So I don't know. I'll try to see if I could find out, but I don't know, you know, what the capabilities are.